started. People tend to come and go. See, I'm sliding back into the frame. People tend to come and go, and I imagine that'll happen here. Hopefully they realize that this is one of the parts of our three-part series that I think has some of the most significance. And part of that is because of the people we've been able to get here to come and talk about this today. In general, Todd Campbell and Debra Natzke are the people that really coordinate referrals and the whole idea of substance abuse services in Dane County. So the fact that we were able to have them here to talk about it is just, I think, an exceptional, generous use of their time, and really appreciate that. On a more specific level, Todd is the Alcohol and Other Drug Abuse Service Manager for Dane County, which contracts with 21 different agencies to provide more than 60 programs for prevention, treatment, recovery from the abuse of dependence on alcohol and other drugs. Todd received his Master's of Social Work from the University of Southern California, whose weather is very similar to ours. So, yeah, okay. And is a certified independent social worker. He's worked in county government throughout his career. Prior to managing Dane County's AODA services, Todd was a supervisor for Child Protective Services in Rock County and in Eau Claire County, and actually it's the CPS folks that really spawned this. They wanted some information for people other than substance abuse providers. He also supervised delinquency intake, the birth to 3 and family support programs for Eau Claire. He's worked in San Bernardino County, California as a drug program coordinator, where he was involved in establishing new programs designed to treat pregnant and parenting women addicted to alcohol or other drugs. Debra Natzke is the Dane County AODA program specialist. She's been working in behavioral health for over 30 years. She must have started when she was 3 or something, I guess. She was a practical nursing degree from Northeast Technical College, a Bachelor of Social Work from UW-Wisconsin in Green Bay, has been a certified clinical substance abuse counselor since 1989. Her professional experience varies from inpatient hospital services to case management for homeless individuals to psychiatric triage and community emergency services unit, all very social work relevant services. She's responsible for all of Dane County funded AODA residential treatment authorizations and utilization review functions. She also serves as advisory board for Dane County alternative sanction programs, drug court, OWI court, and DART are examples of those. So with nothing further, we're going to turn it over to our 2 guests who are going to talk about the referral piece. We talked about assessment, intervention, and now what do you do when people may be willing to get some help. And we do have slides from the first 2. If after this you want to pick one of those up if you did miss one of the first 2 to 6. So.
All right. Thank you, Nick. Thanks for the introduction. I'm happy to be here. I'm actually also happy to be talking to the remote side, or those who couldn't be here. In my first year as an MSW student, I participated in an off-campus site, a remote site. So I know that experience real well, how hard it is to juggle multiple things going on. But yeah, I did, in my second year, I was at USC and on the main campus, and the weather is, we had rain once, I think. But I'm here to talk to you today about the alcohol and drug services system in Dane County. That's what I know, that's my expertise. But as Nick said, I've worked in a couple of other counties here in Wisconsin, and I can tell you that what Debra and I are going to talk about today has application to just about every other county in the state. Counties are set up differently. They have different services that are available and different services that they authorize. But these services that we're going to talk about today are available statewide, and so the fundamentals of making a referral are the same no matter where you're practicing as well. So why is this relevant? If I'm going into CPS or juvenile justice, you probably have gotten a flavor of this already if you're doing your internships, as to the prevalence of alcohol and drug abuse and the prevalence of alcohol and drug abuse on caseloads. I know you've been exposed in the previous seminars to some of the prevalence data, but on a CPS caseload, a conglomeration of national studies back in the 90s found close to 2/3 of a CPS caseload has at least one parent that's drug and alcohol involved and has a drug and alcohol problem that needs to be addressed. There was a survey done of Dane County Child Protective Services caseload a couple of years ago, and that survey of social workers of their caseload found that over half of the cases that were open for ongoing service had an alcohol or drug problem that was identified in at least one of the parents and that needed intervention. So it's there, it's present, and actually probably your best approach is if it's not there, make sure that it isn't there. You need to confirm that it's not there. Just another reason to look at alcohol and drug abuse services in studies of former foster children that have been done. Former foster children, when compared with the rest of the national population, are about twice as likely to develop an alcohol dependence issue and about 4 times as likely to develop a drug dependence issue. So it's something that needs to be addressed in families that you're working with, both with the parents that you're working with and with the children that you're working with. In 2011, and this is a pie chart for Dane County. You could probably replicate this in most areas of the state. About 3/4 of the problems that our treatment agencies addressed, the primary problem was alcohol. Now, in the last couple of years, in Dane County in particular, in southern Wisconsin, and a couple of counties in northern Wisconsin, there's been a lot of attention paid to the prevalence of opiates and heroin and the overdoses that people have been experiencing. And that is indeed a growing problem. One thing that's a piece of this data, it includes people who are coming in for assessments related to an intoxicated driving offense. It includes data for people who are being taken to detox, which is primarily alcohol and represents a lot of people. But in our treatment agencies as a core, you could probably trim off, about 10% for that intoxicated driver or the detox experience, bring that down to 60. The opiates actually in the last year or so have continued to climb up, but it's no more than 25% of the people that we're seeing have a primary opiate issue. Alcohol is still number 1 in Wisconsin. And so as you're working with families, and if you think that what you're looking for are presence of hard drugs, take a second look at alcohol because it's there in Wisconsin, and something that we need to pay attention to. Now in Dane County, we do have a significant number of agencies available to see people who have alcohol and drug problems. We have 25 agencies that are licensed through the state with a substance use specialty. So agencies have to be certified in order to provide drug and alcohol counseling. We have 25 in our county that are licensed. When you're looking at, when you're working with a family and you're looking at a referral, there are a few things that you need to keep in mind as you're working with that family. The first thing to keep in mind is, who is the payer? Who's going to be paying the bill? And we're going to get into each of these. Who's going to be paying the bill for the treatment? Second is the modality. What kind of treatment is necessary? How much treatment is necessary for this person that I'm working with? Next, the agency, that I need to be looking at, and then follow-up. What kind of follow-up do I need to do, and how do I put that into action? So now, who's the payer? Actually, Debra's going to talk a little bit about this item.
In Dane County, we have several agencies that are responsible for HMOs. How many of you have an HMO, a provider? Typically then, if you're looking for treatment services, that would be your provider. That's a combination of psychiatric services and AODA services. If you also, it could be a payer, it could be Medicaid, Medicare. If you have SSI, Social Security Disability, they also pay for substance abuse treatment at different levels. If individuals have no means of funding, they have no way of funding treatment at all, then it is Dane County. Then they come to us, and we have a budget that will assist with different levels of alcohol and drug treatment.
So, yeah, Dane County is a payer in our county, but within Dane County, there are several other entities that will pay for drug and alcohol treatment, and that's the first important piece that you need to know, because all decisions are based off of who's footing the bill, because that limits that each of these payers has a cadre of agencies that they work with. They have a cadre of services that they're able to offer. So the first question that you need to answer is, who's paying the bill? Now, if there is no HMO attached, no Medicaid, no Medicare available, Dane County is the payer of last resort. And we have an annual budget of $7.5 million, which in isolation sounds huge, and it is a large amount of money for you and me sitting in here, but we're also talking about $7.5 million that goes to fund prevention services throughout the county. It funds recovery, outreach, information, and referral services throughout the county. It funds a lot of some public safety measures that are taken within the county. So the $7.5 million kind of gets sucked up really quick, and I never thought in my lifetime I'd be able to spend $7.5 million, but I seem to do it every year pretty easily enough. We get that the funding actually comes from multiple sources. About 30% of the money we get comes from the federal government, which may actually change as the Affordable Care Act comes into play. We're not quite sure how it's going to change, but we're being told it'll probably change. So we'll find out. Dane County, the tax levy from Dane County does contribute about 30% of that $7.5 million also. That is unique to Dane County. Dane County supports AODA services in a way that not a lot of other counties do. So that, a large part of our budget does come from the county tax dollar. We also get about a quarter of our funds from the state of Wisconsin through some special programs that we're able to operate and some grants that we have. About 8% comes from the clients themselves, either through payments for some of the services that we offer or through some of the benefits that they have. And then we have other sources of revenue that makes up the rest of our funding. About 10% comes from miscellaneous pots of money that we're able to find, the couch cushions and that. So all that goes to fund the prevention and treatment services that we have available. So that's what we have as a payer. So what you need to figure out next is what level of care is necessary for a person to receive treatment. And I don't know if you want to talk about the assessment process here.
It sounds like from your other talks you've already gone through kind of the assessment process and how that gets done.
It would be good to just kind of highlight, I think.
All right. So say for instance you were looking for AODA services and you had an HMO, and typically on the back of that card there's going to be a number for behavioral health. and that's the number you would call to begin the process of receiving an assessment to find out what level of service you would need. It's not unlike going to the physician with a ear infection and what type of antibiotic, varying with the strengths, they're going to prescribe for you. So once the assessment's completed, then they will they'll let you know if it's going to be outpatient services, if it's going to be intensive outpatient, day treatment, residential, inpatient, or if you need immediately to go to the detoxification center, which might be the starting point depending on the level of chronicity or use.
And so, you know, just to flesh out some of those levels of care that are available that you could be assessed at, and as Debra said, it's based on how long you've been using, how much you use at any one time, when was the last time you used. If the last time you used was relatively recent and you have been using for a long period of time, the first stop may be detoxification, which provides a safe withdrawal so that somebody can become drug-free, because if I have drugs in my system or I'm going through withdrawal while I'm in a treatment program, the physical effects, the psychological effects of that withdrawal are going to stop me from participating in that treatment program. I'm just not going to attend very well, and I'm not going to grasp what you're saying if I'm awake. So detox provides that withdrawal, which is humane and protects the patient's dignity, and it prepares that person for ongoing treatment. Now, detoxification can happen on an inpatient basis. It can also happen on an ambulatory basis, outpatient basis, with the proper medication and the proper environment. That if somebody has a supportive environment where they can go through those withdrawals, you know, it can happen there. Inpatient would be the next level of treatment as far as intensity goes. It's in a hospital setting where there's 24-hour nursing care available. There's a minimum of 12 hours per week of treatment, and actually we do have a handout available which will lay out sort of the particulars of these next few slides. There's a minimum of 12 hours a week of treatment that's provided in an inpatient setting. They have to develop a treatment plan within 4 days, which actually to us seems kind of long for that requirement, but there it is, because the inpatient length of stay is typically less than a week. But there it is, a treatment plan is available within 4 days. Their next level of care, go ahead.
I just want to interject that there are no inpatient treatment options in Dane County.
Yeah.
None of the hospitals in Dane County provide that. Baraboo, St. Clair Hospital in Baraboo would probably be the closest one. Rogers Memorial in Oconomowoc, Rosecrance down in Illinois, Rockford, and St. Joseph's in Marshfield on up. Chippewa Falls, Ellie Phillips has one, but that option does not exist here in Dane County.
Residential treatment is the next level down. It's usually in a community-based setting, what's called a community-based residential facility. They provide 24/7 care, 12 hours per week. You're going to see that a lot. Their treatment plan also is available within 4 days of a person's admission.
This is the rehab with Dr. Drew, right? The residential care. Anyone see that? 30 days with Sandra Bullock. This is the residential. And the 28 days kind of came into fashion when the Minnesota model began in the 80s. And so I don't know what's magical about the 28 days, but funders are taking a look at how folks can have kind of safe, supported treatment in the community and less in residential settings. In Dane County, we contract for 2 providers. There's 2 providers to be had. It's Tolarians, Teresa McGovern Center, and Hope Haven, operated by Catholic Charities. And both of those agencies offer, well, Tolarian, for instance, offers maybe your HMO if you called, and that's where they bill HMOs. They contract with other counties. Hope Haven also contracts with other counties. You could privately pay there, or if you had no resources, that Dane County could pay. So that's the, where you're, if you've ever seen some of those shows, that's what it's like.
Going down in intensity is day treatment, and this is where counseling happens on an outpatient basis, but again, that 12-hour minimum of counseling per week per person is available. And the most you can go in any 7-day period without counseling is 72 hours. So people are going there usually 4 or 5 days a week. We have a couple of agencies in Dane County that provide this service that we contract with, but there are others that are available. We contract through ARC Community Services and through Tolarian for day treatment. Also, Meritor has that available?
Yes, New Start through Meritor. That would be your P Plus provider. Your Dean providers, Unity would be through Gateway through UW. They provide the IOP for those payers.
And again, the treatment plan is available after the second visit. John, do you have a question?
Just a comment on ARC being the gender-specific, women-specific treatment.
Thank you. Yeah, that's a nice, yes.
Right, yeah. For those who didn't hear in the microphone, ARC is a women-specific program. They do have services that are supportive of women who are caring for children as well, so they have child care on site. They arrange for transportation to and from the agency, so it's actually a good fit for a lot of families. And then the least intensive but most common environment for AODA treatment is the outpatient setting. Fewer than 12 hours of counseling per week, and really this is should be based off of the client's needs as to how many hours per week an individual has of counseling. And so it's in a mixture of individual and group settings. The agency that Dane County contracts with primarily for outpatient services is Journey Mental Health Center. We also work with Tolarian, with Meritor. We have some outpatient counseling available, and with ARC Community Services. And again, a treatment plan is supposed to be available after that second visit. So this is a summary of what I just went through. This will be on the handout that's available afterward. If you take a close look, in this first column here, the counseling is virtually the same. I mean, the counseling requirement is the same. It doesn't mean that all agencies have the same counseling available. They don't have the same staff available, sometimes between agencies, same credentialing of staff. And they also don't always offer the same intensity of service. So that's why you want to look at the agency. But inpatient, residential, and day treatment, it's all the same. It's the setting that's different, and it's that setting where that needs to be taken into account when an assessment's being done and we're determining a level of care. So that $7.5 million that I talked about for Dane County, this is how we distribute it. And when I was talking about $7.5 million going pretty quick, there's a lot of different categories here we got to spend it on, so that's why it goes quick. But as I said, outpatient's the most frequented level of care that people are going to, either starting out or on an ongoing basis. When most people, and we get several calls a day about people who are looking for treatment, they are all looking for that 28-day program. That's what people envision as being alcohol and drug treatment. But actually, for a lot of folks, outpatient is an effective and meets the needs of a lot of people who have drug and alcohol problems. We don't always require that somebody goes away to a program and then come back because they're cured. It doesn't really work that way. Just moving on down here, here's that residential funding that we have available. We also spend a little over $500,000 on day treatment. It's actually inching up closer to about $750 now for day treatment. And then halfway house or transitional residential is a level of care that we didn't really talk about. I don't know if you want to say a few words about that.
We contract with Catholic Charities, again, to provide that transitional residential care. And it's a step down. Primary treatment has to be completed prior to the acceptance of that setting. And it's not very common that counties have this offering. So they have two houses. One you might have heard of, the Chris Farley House, and the other one is called North Bay Lodge. And the authorizations, again, private pay, you can go there out of private pay. Your HMO might fund that level of treatment, but for those without any payer source, Dane County does. All the authorizations come through our office, and then utilization review is done weekly to take a look at what their goals were for entering treatment, where they're at in meeting those goals, what's keeping them from stepping down into a lower level of care, and the authorizations go week by week with a maximum stay of 3 months.
John?
Would it be accurate to say, Todd, and that when you said the thousands at the bottom, that that's kind of the average cost per person? If you took all the people who received outpatient services in the year and how much the dollars went into it, that it's roughly a per person cost on this chart, or not?
Well, no, on this chart, the 1,500 there, that's actually 1.5 million. So yeah, the unit is in thousands of, so this is, the 500 there on the chart is $500,000.
Got it. Thank you.
If you break it down per person, what we typically spend in an outpatient setting, it does hover around $1,000 per person that are seen. So yeah, it does come close to that. But yeah, this, yep. So next, which agency? After you've determined who the payer is and who's going to be footing the bill, and an assessment's been done to determine what the level of care is that this person needs, a determination is made about which agency is going to meet that person's needs or not. And this actually may be a good place to talk about our utilization review process and maybe what you know of other payers' utilization review process, because that can have a lot to do with which agency is chosen for a particular individual.
Right. So after the assessment's done and it's determined that you need outpatient treatment, let's just start there, the payer, Dean, Physicians Plus, Group Health, Dane County Human Services, is going to help you decide which agency is going to help you with your care. If you need trauma-informed care, that's gonna drive the decision. If you want gender-specific care, that's gonna drive the decision. If you want opioid replacement therapy, again, that's gonna drive the decision on to which agency would be a best fit for you. And we, again, are providing a handout with some of the details of the agencies on the back. Mm-hmm. So it'll tell you, which agency we provide with and what the level of care is that might be useful for you. And at the beginning of 2012, late 2011, we changed our intake process for Dane County funded residential services. Prior to this time, if you were indigent, you had no other payer source, you wanted Dane County to fund your service, you would just call. You would just call the residential provider and say, I want to be put on the list, and you'd be put on the list, and there was this kind of stagnant wait list that would move when or maybe, and so you may be on a wait list for 2 to 3 months depending on the time of the year, and then they would do the screening and then they do the admission. And so we wanted to kind of do it in real time, do that assessment, that screening in real time. So we developed a clinic, if you will, a walk-in clinic on Monday mornings, 9 o'clock. We take all comers. Anyone who's interested in a county-funded treatment for residential services can come. We have 2 assessors that we contract with through Journey Mental Health Center that are there to assess, and it's really a team approach. I do the screening from my office at Human Services to determine if this person has other types of funding. Are they a veteran and could go to the VA? Then we talk with them about how to go that route. Are they under the supervision for the Department of Corrections, and they also then would have those residential resources, we refer that way. If they have Medicaid, Medicare, we help them with those services. So I screen them in first and determine which people would be assessed and triage in what order. To those that are indicating that they're in current withdrawal, we have the nurse come in then right away, because our assessments are located at the Detox Center on Industrial Drive. That's Tellurian. And they can then, if they come in and they're in withdrawal, the nurse can assess them and take them right over to detox. If they're not in withdrawal, ready for an assessment, we do the assessments right there. If they assess, for instance, to be eligible or it's recommended, clinically recommended for residential care, we right then can get them right over to Hope Haven or Tellurian, our residential providers, same-day admission. So that's been the process, and of course since we had some cost savings from our residential, we're not using as many, we added some money to the day treatment providers, so we don't have a wait there either. So there's no waiting for those higher end services in Dane County. At this time, there hasn't been for the full year of 2012, and we typically, our average last year was 9 people on the clinic on the morning, and so everyone who comes talks with an alcohol and drug counselor. Question?
Is that located beyond the Beltline, the office?
Right, the question is, where is Tellurian located? It's off Southtown Drive, so if you're going on the Beltline, you take a right off the Southtown Drive exit, you would go right to the Super Walmart, or left to the Super Walmart, you go right, and the detox center is right down.
Okay. So is there accessibility via bus?
Yes.
For patients?
Yes.
And is that accessibility, do you know like how easily it is? Like, is it more than one transfer in order to get out?
Well, it depends on where you're
downtown area.
Right. It depends on where you're coming from.
Okay.
There's going to be some transfers, but what we have started to do, though, if they don't have transportation, and we've been recommending residential treatment, we have a peer specialist now that can help them, because we recognize that there's going to be perhaps some heightened anxiety or some, buyer's remorse. I'm not sure I wanted to do this in the first place. Drop me off here. So we have a peer specialist go with them and help them get admitted then to the residential setting.
But there isn't anything like that to help somebody get there?
No, that's correct. Yes?
So also in terms of assessment for other levels of care, if Dane County is going to be doing the funding, is this where it happens as well?
So the question was for the assessment for other levels of care, and this assessment on Monday morning is for the residential level of care only. Now we use the Uniform Placement Criteria of the state of Wisconsin, UPC. That's our assessment tool, and we made that determination to use that tool because the other contracted agencies are also using that tool, so we wanted to be uniform throughout our system. We may determine that they need a lower level of care, IOP, day treatment, or outpatient, and we will make those referrals right then. But you do not have to come on Monday morning to the clinic for those. If you're only wanting outpatient, then you can call the outpatient provider yourself if you're Dane County funded. I don't do it's not required to have an authorization from the county for those levels of care.
Is that true of other payers?
That is not true of other payers. If you take a look at your insurance card, you would need to get authorization for all levels of care if you were in an HMO, for instance. And then there would be utilization review for every level of care.
And then, so how would a person become Dane County eligible?
Okay, the question is, how does a person become Dane County eligible? If they come on Mondays, they fill out a one-page screening form, and there's some key questions on there. Are you Native American? Are you affiliated with a tribe that might have some resources for you? Are you a veteran? Are you a DOC client? Do you have other...
Department of Corrections.
Department of Corrections, sorry. Do you have other sources of payment? And I review those and I screen those, and those that might have another payer source, they talk with me or with the director at the detox center, and we can determine what's the best fit for them. And those that have no other payer, those are the people that then we can authorize, do the assessment, and authorize funding for treatment.
But if they're not looking for residential
Okay.
care,
Right, so if they're not looking for residential care, say you wanted outpatient care, you would go to Journey Mental Health Center, then those agencies are responsible for meeting we contract with those agencies for services, and there's, you have to be over 18, you have to be a Dane County resident, you have to meet financial indigency criteria that's set up by the state. They do their own intake process with that. Yes?
One question. So, so say I'm a Madison resident, don't have a job, no insurance,
Mhm.
etc. I've been drinking for a while. Finally, one day I'm like, I had a fight with somebody, want some help. Don't necessarily feel like I want to stop all the way yet. Don't know where to go for help. So I call up Journey. What happens then?
Journey would let you know about their open intake process. And you could come in to Journey, get an assessment for the level of care. If you called the crisis unit at Journey, you might spend some time on the phone with the counselor to kind of go over your options. Do you want to do some alcohol education? Do you want to go to an AA meeting? Do you want to be full-on assessed for, you want to go to harm reduction, you want to go to smart recovery? I mean, there's different levels that you could kind of tiptoe around and see what you're willing to do.
Okay. So how does at this point, I don't have insurance or anything.
Mm-hmm.
Are they able to make a determination that I am eligible for Dane County reimbursed services?
Again, agencies themselves make that determination when you come in for an intake. They'll give you a financial form that you'll fill out, and based on your income, your county residency, your age, they would determine.
Our contract has the eligibility guidelines in the contract with the agency. And so what we do, the county makes the eligibility decisions for residential care. For the lower levels of care, less intense levels of care, the agency themselves are making those decisions on behalf of the county.
Gotcha. So you could essentially receive same-day care without, so Journey wouldn't have to call you and say, hey, I got this person,
Right. Journey for outpatient care does not need to call the county to get permission to serve an individual. Now, in some other counties, they have what we're calling centralized intake for all levels of care. But in Dane County, it's only for residential level of care. Amy, you had a question?
I did. How many times can you go to residential, or how are decisions made about kind of the frequent flyer that keeps coming back every day?
7 times. 7 times, that's your limit. No, kidding.
The question was, how many times can an individual go into residential care? And we haven't determined that there's a set amount of times, because I think we have to leave room for individuals and their different issues that they might need. One of the women at Hope Haven calls it a tune-up, and they might need to go into treatment. We were happy to reassess them to see what level of care they would be best suited for at any given time. We also have case management, alcohol and drug case management available for those folks that seem to be treatment recidivists, that seem to have gone through, and we really have to ask ourselves, is it wise, is it prudent, is it clinically best practice to put them through the same treatment again, or do we move them then into transitional residential care, or do we put together a package with a representative payee, some transitional housing, IOP, and a case manager? And so we've been able to do that with with more of the chronic folks in this past year because they all come to the attention of the county.
Yeah, basically, we don't want to keep doing the same thing over again, expecting a different result. If something's changed in that person's life from the last time that they were in residential, and it's visible, and it's clear that they're going to take a different advantage of the program, we'll put them in. But yeah, we try and tailor those treatment plans. Nick?
Yeah, we talk a lot about the substance abuse piece, but we know there's a lot of co-occurring conditions. So you have somebody who's got a varying degree of a co-occurring disorder, and as the person who's the first point of contact, you recognize this person's got more than substance abuse issues. Do they go through the same process? Is there a different branch of your department that takes care of those with mental health issues and substance abuse? I guess, and is that budget shared with MH services, and how would that play out?
In Dane County, we do have a separate division that funds mental health related services. That said, all alcohol and drug certified agencies in the state have to have either expertise in-house to deal with mental illnesses or have to have a solid referral source to work with people who have mental illnesses. So everyone is either equipped through duly credentialed staff, or they have the referral avenues in place to work with folks if they go beyond what they're capable of doing.
So if our folks are with a family and they recognize that there's, it's not a florid axis 1 schizophrenia diagnoses, but there is some axis 1 mental health issues. Would they be better, and substance abuse is a presenting maybe problem at that point, would they be better served to just have them go through this agency, hoping the assessment person would recognize this additional need, or are they better served knowing this person has a mental health history to have them go to that other branch?
I guess what I would say, and Debra, you might have a different answer, but what is your motivational interviewing skills? What are they telling you? I mean, where is this person at in contemplation on changing their substance abuse? Where are they on contemplation on changing their symptomatology from their mental illness? And go with where they're at and take advantage of where they're ready to change.
At the county, there's a mental health manager, and then there's my counterpart in mental health, there's a specialist. And we often see folks, for instance, on the inpatient side with mental health, that clearly that psychiatric admission was driven by their substance abuse disorder. So we frequently discuss and determine which agency are they better served by and in what way, or all of it. We combine that.
And in many other counties, the funding is together within the same structure, so it doesn't make as much difference there. But all of our agencies have the expertise to either work with individuals who have the co-occurring disorder or know who to reach out to. There were other questions?
So if a person can't get there on Monday morning at 9 a.m., is there other options?
If, there is some value in a social worker, if you're working with a family, to tell us about somebody who you'll be sending to that Monday morning assessment, because then we might be able to bypass that assessment depending on the person's history, what we know of the individual, or come up with a plan to get them there on Monday mornings. When we started this, one of the main concerns was exactly what you're raising. How are people going to get there? We looked at data from 2011, and throughout 2011, before we started this, we had an average of 6 people added to our residential wait lists. And in 2012, after we implemented this, we saw an average of 9 people a week. So we went from 6 people a week to 9 people a week. So people are finding us and people are figuring out ways to get there. We've had people who've stayed there overnight to make sure they get their spot because they're ready to go. And that was one of the things that prompted this change too. So we wanted to expend the resources that we do have on the folks who are ready for treatment. We had a lot of folks who were coming into residential treatment because it was a place for them to come in out of the cold, and they weren't interested in the treatment part. We do have housing resources that are available in Dane County, and you know, people can take advantage of, and we encourage folks to take advantage of that. But if you're ready to come in and get to work on recovery, then we're there for you, and we're ready for you. So people do come.
Situations where folks can't come on Mondays is if they're in a local hospital. That's typically what the calls I get from a discharge planner or a social worker. You know, we're discharging him on Wednesday, he really needs to come, but I don't think he'll be safe. And so what I've done in those cases is either work with that family to keep them safe until Monday, or transfer them immediately to our detox center in what we call our treatment readiness beds. And they stayed there until they could get to the assessment on Monday. Sometimes also, if an assessment has already been done at the hospital, and I have authorized direct admission to residential from the hospital.
John, you had a question?
Just to comment that in the broader community, there's a lot of other people who are receiving AODA services that never touch your system.
Right.
If you will, through the county. Thinking of the faith-based agencies, the not-for-profits, where individuals might go, and some of those agencies have sliding fee scales yet,
Yes.
where people are simply buying their services individually, separate from the county's service system, right?
Absolutely. And that's true in other communities as well. Yep, absolutely. One last thing that I do want to get, I know we're hitting the top of the hour here, is you want to be sure if you're making that referral and you're going to continue working with that family that there is adequate follow-up on your end being done. The reason I included when those treatment plans are available from agencies is to make sure that you know what that treatment plan is. What is that person working on, and how are they working with that counselor? Particularly if somebody's in outpatient care, you want to keep that line of communication open with an AODA counselor. And just a quick word about the outpatient setting. Folks are scheduled back-to-back typically, and if they have time, it's at 10 to the hour to the hour. They have that 10 minutes available maybe. So you want to figure out how to communicate with that counselor so you know what they're working on and what kind of progress is being made, because that will affect what happens after counseling occurs. 90 days is a key benchmark that you want to work toward, and that is to keep someone in treatment for at least 90 days. If somebody's in treatment for 90 days, that is associated with positive outcomes. So if somebody's in treatment, now the average length of stay in our residential programs is 20 days. And that means they're going to have to follow up with another level of care, whether that's day treatment, whether that's moving to an outpatient agency. So if you're working with somebody in residential, don't think your work is done, it's just beginning. You want to make sure that you're working on that discharge plan with that counselor to make sure they're getting to that next level of care so that they can be in some sort of treatment program for at least 90 days. And then finally, if somebody is concluding treatment or wrapping up with treatment, you want to know what that relapse prevention plan is. All counselors should be working on that with someone who's in treatment. You want to know what's involved in that, who the resource people are, and what the triggers are, so that you can pay attention to that as you're working with that person as well, so that they can continue their life in recovery. I know I hit the top of the hour, but we are available for additional questions if there are some out there.
This is a question that I'm thinking we maybe have to cover at a different time, but I'm just curious for myself. I know that DSM5 in May is coming out, and they're changing diagnosing substance abuse dependence is going to the wayside, and it's going to be substance use disorder. And I know a lot of the statutes and a number of decisions get based on whether or not it's a dependence diagnosis or an abuse diagnosis. Is there a team, is there a committee? How are you guys looking at the implications of the new DSM as it sometimes even just applies to wording of different document or different kinds of assessment outcomes, and you know, how is that, you know, there's going to be a lot of implications with the way they're changing some of the diagnosing, and so is that something you guys are working on? Is there something that we should be staying in tune with to be able to see some of those changes, or even participate in if you want?
We do have some programs that use dependence as an admission criteria. You know, we haven't gone to, okay, what's it going to be now? Yeah, at what place along the continuum does that admission change? There are some other factors actually, and this happens more in our alternative sanction programs, our drug court, our TAP. What we're focused on in those programs now is a person's likelihood to get rearrested and reconvicted, and actually it's that criteria that we've been having the most discussion about, and then we will then adapt to get to that substance use disorder redefinition and find that out. So it will be coming, it will affect some programs, but it's not kind of the top priority at this point.
Because they're eliminating that criteria.
Yes,
So,
that's what,
Yep.
well,
yeah,
if you
so-
keep up with it. It changes, but yes.
Yeah,
Right, I mean, that seems like that's...
That seems like the direction they're going.
right.
So,
Joe, you had a question?
Yeah, so, I mean, so as a payer, you are in a position where you have control of selecting what agencies you will reimburse for outpatient services, for example, which gives you kind of a lot of power in influencing services that are offered. So I was wondering if you wanted, do you think that's accurate? And two, do you use performance measurement, and what kind of performance measures do you monitor these agencies on as a criteria for reimbursing them?
Yes, we do. In the way that our contracts work, and we like to work with our contract agencies, is more in a cooperative fashion. So we do have expectations and benchmarks, and we have had agencies, and it depends a lot on what the programs are, but we have had agencies that haven't met expectations, and we've had to end our contracts because they're not meeting those expectations. But we try and come up with cooperative expectations that are going to, you know, reflect on the work that agency is doing. So things like outcomes, successful completions. For our alternative sanction programs, we look at rearrest data. You know, we look at how individuals are transitioning from unstable lives at entry to more stable lives at discharge. So those types of things are what we look at. But generally speaking, we try and work cooperatively to identify where are there gaps in the system, where do we need to hone things as a system so that we can function well together. The agencies that we have together in that chart that we contract with, we try and get them talking with each other so that those referrals between levels of care can work adequately, for example. John?
Just maybe a closing comment. If a person with a substance abuse issue is a minor, a youth, for parents or for schools and other helpers, the point of entry, would it still be the ADAP agency, the Adolescent Intervention
Yes.
agency that's connected here to UW, as a starting place to get that screening, assessment, and linkages to different resources?
Yes, it is ADAP, Adolescent Assessment and Intervention, program. And they are listed under the outpatient column of the handout that we have up here, but they're our largest adolescent service agency. And they are doing some exciting things there. They have a new evidence-based practice available there, so it's a good agency.
In fact, I'll just piggyback on that, not to steal you guys' thunder, because I want to say thank you again for coming. This was very informative, and above even expectations, even though I knew you were going to do a good job. But next Thursday, we have 2 presenters who are actually at ADAP being trained in multidimensional family therapy, which is the model that Todd's referring to. And they're actually going to do a brown bag presentation about that and their experience with that here. So that's a good segue.
It's an evidence-based strategy that comes out of Florida. ADAP is the only agency in Wisconsin that's doing this right now, and we're actually the envy of the rest of the state because we have multidimensional family therapy here in our backyard. So they've been going through the training, they've maintained fidelity, and it should be an excellent presentation next week.
Thank you so much.
Thanks. Thanks. Handouts on the table.